welcome to the 13th annual Holt 2.0.
13? Oh my God, we have an unruly teenager on our hands now.
It's really funny to sort of think about it being 13. I think, when the movement was younger, if you will, we broke some things. I think we, in some ways, we're breaking barriers, but now we're older, and I think it's time to raise the bar. So I'll be doing a part of this talk and talking to you about what I think the stakes are and what the new criteria are to raising that bar.
All right, and I'm going to go away, but I'm going to come back in a few minutes and say we're not quite done breaking things yet, all right? There's still a lot more barriers to overcome. There's a few more castle walls to storm. I'm going to talk a bit more about how the new healthcare services and the technology are going to build out a very different healthscape.
Okay.
So Indu, take it away.
So in 2007, I think we had a dream. We wanted a health and healthcare system that was using enabling technologies in new ways, and we wanted technologies that were user-centered, that used data to drive decisions in an intelligent way, and we wanted technologies that played well with others, that could share data and that weren't siloed. That was our dream, that health and healthcare would get better if our enabling technologies had these three characteristics. And in some ways, this was our definition. I proposed them as our definition of Health 2.0 technologies as compared to the generation of health IT that came before. Fast forward 12 years, and in many ways, our dreams are a reality today. So if you think about each of those criteria, you're going to meet companies like over the next 2 days like Mommy, where we have user-centered care. We have user-centered design. Mommy has the radical notion that a mother and baby's health records ought to be in one place, ought to be accessed in the same interface, as opposed to having data at the OBGYN's office and the pediatrician's office. So this idea that the user matters and technology needs to adapt to that. So we have user-centered design. We have data-driving decisions. This is my LARC profile connected to my 23andMe profile, where I now have my genomic data, my wireless scale data, my iPhone monitoring activities, a chatbot that regularly asks me too many times a day what I had for lunch and dinner, and I have to be embarrassed about reporting back sometimes. But data's driving my decisions multiple times a day now. And we're certainly playing well with others, thanks to FHIR and other API protocols used by the biggest players and the smallest ones. We now have an ecosystem that is much more interoperable than it was when we started out. But be careful what you wish for, because what I think I'm seeing now is that those same characteristics of technology that make our health tech ecosystem so impressive today could be turning our dreams into a nightmare. Let me give you an example. So in a world where technology is always on, and it doesn't matter what environment we're in, we really have to ask hard questions about our future direction. So talk about user-centered technology. Are our technologies getting too personalized and too user-centered? This is Seth Stevens Davidowitz, the author of Everybody Lies, and he's wondering, kind of in a funny way, how does Facebook know to send me an ad for hair loss other than by analyzing my photos with facial recognition software? Because nowhere else in my internet behavior am I giving up that data point. And this taken, into sort of a more serious realm, a story of somebody who was falsely accused of a crime because police were using GPS to track somebody on their phones. Are we too data-driven? Our technologies are so good at using data to drive our decision-making, even when we don't want them to. This is about Alexa holding on to data, even when you delete your audio files. And are we playing a little too well together? With outwardly very different companies belonging to the same parent company via acquisitions, how clear is it to us about how our data is being used and shared? So Google and Apple have each put out manifestos on privacy. But the fact is, we're living in a world where the user base of Facebook is greater than the population of most countries. And Facebook was recently fined $5 billion by the FTC, turned around and grew its user base on a daily and monthly level 8% in the last quarter. So it didn't affect the growth at all. So I think the world is wondering how to react here. And I think there's a fundamental ambivalence. This is a story about Denmark, who appointed the first ambassador to Silicon Valley, almost treating Silicon Valley like a superpower, like another country needed to negotiate with, while at the same time appointing a commissioner who in her first term levied heavy fines against the tech giants, and so she's back for a second term. And I think we face that ambivalence in this country too, in terms of our relationship to technology. The US Justice Department has put out antitrust reviews against big tech, while last week met with the intelligence community with the same players to figure out how to secure our elections moving forward. So health tech is not immune to this conundrum, right? We've had a spate of acquisitions, partnering activity, investments that have raised the question of whether the company you thought you were giving your data to is the same company where your data ends up. And in this new data economy we live in, our data has value, and the entities that hold it know it, and of course, and are open and transparent about monetization strategies around that data. It's something Cerner's beginning to do. Epic has been doing that for a while. So how do we shift this conversation in the early days from data access? Not that those issues have gone away, mind you, but the early days were about, well, give me access to my data. Give me my damn data was the hashtag. And now we're much more talking about this realm of data control. As Eric Topol 2 years ago put out on his manifesto on Twitter about sort of the fundamental concept that healthcare data belongs to each and every one of us. And so now we're shifting this conversation from access to control to ownership. And if I own my data, this is Richard Harris and Gregory Barber writing in Wired and NPR respectively about the question of whether we should get a cut from the money generated from our health data. And in fact, technology companies in this very room are enabling that. So whether it's Nebula with blockchain, Emblema, CoverUs, allowing patients and consumers to control access to their data, commercial use, being able to charge for it. So there are now mechanisms to transfer that power back to patients because we are talking about issues of control. Okay, so health tech as an industry, as a space, has grown tremendously. We're now facing some of the same challenges as big tech, but with great power comes great responsibility. And so we're no longer that sort of box on the left, right, which is maybe a point solution in digital health. We're now full stack companies, as Matthew and I have called the flipped stack company. If you think about a digital health company today, think about, all the way from like a Devoted and a Clover to something maybe emerging. I'll give examples. We're often seeing a tech-enabled platform with some level of analytics and AI, on top of which services are layered. And finally, a care delivery component, whether that's a clinician, a coach, a nurse, a doctor, all on that same technology stack. That's starting to look like a new type of care delivery organization, even though it's a digital health company. So now that we're operating in this new vertically integrated model, or many of these companies are, it's time to raise the bar. And I think there are new criteria and questions to think about as we begin to touch more patients and have more impact and begin to really deliver on those outcomes, which is the good thing. But what are our obligations as well? So we've done user-centered care. Data is driving lots of our decisions, and we're playing well with others to a certain extent. So here's one question to ask as we look at new criteria. Are you monetizing patient and consumer health data? And if so, who are you making money for? There are two examples here of organizations that give us some best practices. Me2B, a new nonprofit working on a code of practice and certification criteria that culminates in a consumer brand. They're identifying who are the good actors with respect to personal data. And Jan Oldenburg and Nancy Lasha just met them last evening, and I wanted to put their work up here. They're coming up with standards for patients to share their data in a way that's safe and secure, that returns power to the patients. That's called patient-centric solutions. So there are ways in which we can follow protocols in this new economy, and that's a question every company has to ask themselves. Number two, what is the relationship of your bottom line to the health of a population? You now touch more lives. Some of you are going at risk for the outcomes you plan to deliver. And you're partnering with larger entities whose business models might be different than yours, or whose business models might be changing as we speak. Do you make more money as health improves? Do you make more money as health goes down? Or are you indifferent to whether you're actually improving health? We hope for A, but we want people to think about this. And maybe this is a complicated sort of graph to take in, but it really is going to start to become a lot more important how you're aligned here. And last but not least, what is your obligation to the whole patient? As I described, we're not really talking about individual apps anymore. We're talking about robust, tech-enabled care delivery platforms. That's what many of you in the room are becoming. So what does that mean in terms of if I'm collecting data from somebody, but my job is to treat them for heart failure, or my job is to treat them for diabetes? I am certainly getting more data than just about that one condition. What is my obligation? How am I going to partner in this ecosystem to make sure I'm not leaving care needs on the table and still focusing on my core competence, right? So I was really moved by finding this letter that Don Berwick wrote about a patient he had named Isaiah, and he was addressing the medical and dental students graduating from Harvard, and he said, he told the story. He said, this is somebody, Isaiah was someone who won his battle against cancer, but lost his life to a host of social and economic drivers. Eventually ended up being murdered, but Don Berwick was able to help cure the leukemia, but not the other issues. And he says, quoting Antoine Saint-Exupéry actually, that to profess to be a healer, that is, to take the oath you take today, is to be responsible, to be ashamed of miseries that you did not cause. And it's that awareness that we have an obligation, even possibly beyond the sphere of our own control. As we become those stack companies, we can do more. We have to ask ourselves this question. And it's more than just a referral to social services for the social determinants of health. It goes much deeper than that. So are you helping Isaiah? So I'm posing these as new criteria for us to think about as we enter this sort of the teenage years, if you will, of the movement. And I'm going to be back after Matthew gives some remarks to talk about the implications of this for what we're calling the new healthscape.
Thanks, Indu. So you can clap later at the end. You did a great job. She'll be back. So there's a lot of interesting, deep questions there. I'm going to get a bit more prosaic here. The industry as a whole, as you know, well, I like to say we've been possibly in one of these, right? You've seen this chart. Lot of money flowing into digital health and health technology over the last decade or so now, most of our teenage years, right? Most of our sort of pre-teenage years. We're wondering, when does that happen, right? Well, not quite yet, okay? We've had 3 huge IPOs just this summer. Here's the Focus Health Catalyst. Looking behind the confetti, you can see Glenn Tillman, Lee Shapiro, Jenny Schneider, and Zane Burke from Livongo. Company still worth over $2 billion. And even Chaim Indig from Frisia, who some of you may have seen, any of you were at Health Duber in 2008, saw him launch on the stage there. 11 years later, they've made it. And this isn't slowing down. You look at the Rock Health numbers, the startup health numbers. Yeah, they still don't agree with each other, but nonetheless, they're showing something in the order of this year being about where last year, which was a record, was. And it goes on. There was $200 million for Capsule just yesterday, and probably the biggest round ever from Babylon just a couple of weeks back, $500 million for a C round. So there's still a lot of money in this area. However, in the trenches of clinical care, things haven't changed that much. So what have we done? Well, we spent about $40 billion of maybe the Chinese taxpayers' money putting in EMRs. And what's been the result? Well, one result has been that we've got a lot of pissed off doctors, right? Have you ever seen this? This is the Epic EMR parody account. Apparently the goal of Epic is to create confusion for doctors and to maximize the amount of clicks. There's a similar one for Cerner, by the way. And this is reflective of some feelings the doctors have about what's going on. But perhaps more importantly, what we've done in the last decade or so is create sort of large structures, almost like medieval fortresses, around the big healthcare systems that have taken on more and more market share. I was just in a room yesterday where the folks from Advocate and Aurora had merged across state lines, perhaps castles coming together, I don't know. But in some ways, that's prevented a lot of the innovation in care delivery that we talked about from really getting very wide. This is still the state of the play. I sent out an email a while back, just before the conference, talking about how all the stuff we talk about is really not reality for 90 to 95% of the way the healthcare is delivered. It's still within these castle walls. So how do these IPOs, and I've added Teladoc to the list here because they IPO'd relatively recently and they're kind of in that flip stack mode as well. How do these IPOs play? And I think some of them play into the old world and some play in the new. So what are we doing? Well, we're opening up that data drawbridge, right? We now have the app orchards, we have the Cerner Ignite, we have the Allscripts application store platform. You'll hear a bit more about that later. You have ways that the small guys can play with the big guys and start moving data around. It's getting better. You'll hear from Don Rucker in a minute more about what the ONC is doing. You'll see some stuff from the CMS. So there is data starting to flow in that data drawbridge. We're also getting data into the workflow that wasn't there before, and this is where Phreesia plays. Some of you may remember 5 years ago, I gave a talk about my son, Aero, and this was my wife, Amanda, filling in yet another form about Aero in his first few days. I think we filled in this form 5 times in the few days after he was born. Where Phreesia is, they're just one of the examples of many companies who are allowing you to fill in on an electronic way and get that data into the workflow, into the system. And if you think about what Apple's doing with the Apple Watch and the many other ways we're gathering data from patients, that's happening too. And finally, of course, within the current system, we have the idea of what we're looking at the analytics, and can we get from just doing analytics to actually getting to outcomes? Health Catalyst is right in this space, another IPO that's very relevant here. They not only have got a whole bunch of outcomes measures, they're actually going at risk with several of their clients for improving outcomes. So if their analytics don't help improve outcomes, they suffer. So that's a whole new interesting way of doing it. But nonetheless, all of these people who are playing with the current system are playing in a healthcare system where basically one size fits everybody. All different types of people are treated by same type of massive organization. And I think there are a whole group of people out there, a group of organizations, companies, we'll talk more about this for the rest of the talk, who are sort of storming the battlements, going over the ramparts, going through the moat. Maybe they're in the moat, I can't even tell. This picture I stole. But nonetheless, this is a lot about what's going to happen. Are we going to see these new organizations change? So just to remind you, and Indu touched on this, we started in the world of care delivery, face-to-face care delivery. What we've done in the old world is add services on top of that and finally technology to track that care delivery. And what we're going to now is a world in which a tech platform, which is always on, always monitoring, always messaging, and always measuring, is going to be the fundamental piece wherever it is. Could be in the home, could be out in the community, as we saw yesterday at the Robert Wood Johnson thing, and Robert Wood Johnson challenge. And it also is going to be across the healthcare system as a whole. On top of that platform, we're going to start adding services, and then care delivery will almost, face-to-face care delivery, will almost be a failure. So what does that mean? Well, it means that we're going to do different things for different people. Okay, this is a map of people. You guys will recognize this, right? Healthy people, chronically ill people, acutely ill people. That's sort of the ratio of the population. Somebody clever in the audience. This is the audience participation. What's this the ratio of? Cost. Very good. You're all paying attention. You're right. Great. Okay, and it's probably even bigger. The acutely ill one is probably even bigger than that. Okay, so let's look about thinking about these groups differently. We have the healthy population. Whole bunch of companies have got tools to service the healthy population, whether it be chat bots, online telehealth, online drug dispensing. We'll hear from a bunch of those. But what's going on really here is that people are becoming aware of the cost. Jane Sarasin-Khan, who's somewhere in the audience, has written a great book about consumers in healthcare. You'll hear much more from her. And a lot of that is around this issue. I went to see my kid Aero, made another appearance in the talk. He went to the pediatrician. I got a bill for like a 5-minute office visit and a couple of immunizations for $180. If you go to Lemonade online, you can see a doctor, have a couple of lab tests. It's $42. At some point when people are paying the bills, a lot of people are going to go for these cheaper options. So we are going to see that change. So that's one chunk. How are we going to deal with those folks who are healthy with acute problems? What about the people who are chronically ill? This is where most of the healthcare system needs to make a big improvement, and the current healthcare system does a lousy job of looking after people who are chronically ill. That's not something that happens well inside that castle, because as we know, most of the lives of the chronically ill are led outside the hospital, the big systems. They're at home. So, whole raft of companies are working on this. You all know about Armada Health, a tech platform, plus coaching with some clinical services on top to try to manage people with chronic illness. Our colleagues at Livongo, same sort of thing. They've gone public, partly because of this study where they're able to show they reduce cost for their employer clients. Again, it's a combination of technology, services, coaching with some clinical algorithms and a lot of intelligence behind it. If you think about it, where are the health plans going? Well, the Park brothers are doing Devoted, and Vivek Gopali is going to be here tomorrow to tell you about Clover. What they're doing is really going all the way from membership experience all the way to clinical care in the home, and they're managing that very closely, but either themselves or with other types of or with other types of contractors and partners. And you can see a lot more emphasis on that for people with chronic illness. And even those with acute illness, we're seeing new ways of dealing with those people with patients. So last year on this stage, some of you may remember I had a funny interaction with the folks called from Medically Home. I played an old person, with a walker. But what was going on there, Medically Home, working with folks managed Medicare Advantage plans in Boston and elsewhere, what they're doing is that they are actually admitting people to hospital in their own home with a large technology platform, 24/7 surveillance from nurses, services to the home, clinicians to the home, and they're doing it all for cheaper than a typical hospital stay. So to summarize what I've just said is that we have a world in which this new different types of technology, these flip stack companies, are going to enable us to do a whole variety of very different things, and we're going to start having different solutions for different people, whether they be the healthy, the chronically ill, the people with acute illness, and all the people on those boundaries. And you can expect to see more and more of that from technology as we come. Which does lead us, Indu, to a raft of new questions.
So if this new healthscape is evolving in the way both Matthew and I have talked about, my question, at least, and like many of you in the audience, as we watch the policy debates in this country, is what is the policy environment that we need to really encourage this new healthscape?
Well, I've been watching the policy debates a little bit, Indu, and it seems to me that we have, all the way that barring John McCain, we'd abolished the ACA, to now the Democrats going after each other as to whether they want to extend and expand the ACA, Obama's signature piece of legislation, or get rid of it and go to single payer.
I think that, when I look at these proposals, I shake my head a little bit across the board because I don't know that I see anyone that's really focused on bringing down the total cost of the total side of the bill. We're arguing about who pays the bill. But to me, it's the tech-enabled future that everybody in this room is working on that's really going to get us to those outcomes and to those lower costs. And I'm less worried about who pays for it and rather how we sort of reward and incentivize those models. And I don't think I'm seeing that yet.
Well, we very slowly are starting to see some changes in how the current setup and CMS is thinking about paying for this type of technology.
Right, fair enough. And I really congratulate the new rule from last fall. We now have more codes than ever that reimburse for digital health, over 40 telehealth codes, 15 for mental and behavioral health, and 4 for remote patient monitoring. So it's making a difference, but
it's a little onerous, it's a little slow to implement the rules, it's tough to follow, and it's not sort of seamless, and it's not an immediate use of technology so much.
That's right. So I think just to remind ourselves, kind of how we're talking about today's healthscape, where did we come from? This was the world, I think, when we started out, where there were healthcare organizations, and around them...
The pink dot is a healthcare organization, just
right.
to the code, right?
And around it, bubbled up sort of this ecosystem of digital health solutions, at the time, maybe more point solutions. As we moved along, we had the integration of some of them. Some healthcare organizations did a good job of integrating and organizing this ecosystem. Sometimes there's a third-party integrator, people that came along and said, okay, I'll be a one-stop shop for all of this out there. So there was some attempt at sort of integration. But then along the way, as Matthew and I have now said a few times, we had the development of this sort of vertically integrated technology company acting like a care delivery organization. We're calling that our flip stack company. And I think the conversation shifted at that point from the refrain we used to hear in the early days of the healthcare organizations lamenting, well, you don't understand my pain, to the health technology company of today that is driving toward outcomes and value from the start, saying, your pain is a misaligned incentive system. I understand it all too well, and I'm going to compete with it, right? And so, that's kind of what I imagine the flip stack company saying. And we're seeing this in small companies. This is Moving Analytics out of my neighborhood in Los Angeles. They've raised like $2 million. They're not even up to a real Series A yet. They're doing cardiac rehabilitation in the home, remote patient monitoring, hiring their own clinicians, having their own AI, contracting directly with payers. And here's a company that's not even at the gate yet, Bright Heart Health, looking at a fully integrated stack, if you will, for medication-assisted treatment for addiction and recovery. So what do they offer? Telemedicine, peer chat, coaching, and they're in value-based contracts with Medicaid plans around the country, and they call themselves a medical group. Haven't raised their first dollar yet. So this is the shape of that new of that new type of company. So my question, Matthew, is, and not just to you, but to everybody in the room, and I was having an interesting conversation with Don Rucker yesterday about what we do about this. And that is in this world where I believe specific patient populations are going to be served incredibly well by solutions in this room and in the community. We're going to get people that can deliver better outcomes for diabetes, better outcomes for heart failure, but they're going to do it in specific subpopulations with really sophisticated technology. So now how do we horizontally integrate the new vertically integrated ecosystem? And so it's terrible, I know. I'm calling it
Hio-Vio Indu. Right.
Maybe we'll
Moving
change
Hio-Vio from now on. No, but you're right. But this is actually the critical question,
Yeah.
right? So who is this new value care organization? Who's this going to be in the middle? Who's going to be organizing all these different pieces? And that is an open question you'll get to answer. What is the new value organization? Well, we have some ideas.
I don't know. I mean, so we were looking at the news out of North Carolina, the Medicaid plan there, along with the Blues, moving radically away from fee-for-service to value-based models, investing millions of dollars in social determinants. That could be kind of a new value organization. It could be the state of California that is now working with a very, very well-funded program, creating a portfolio of mental health applications in digital health for over 50 counties. Throughout the public mental health system. Could that be the new value organization? By the way, there's an application deadline. If you're working in mental health, please consider applying for a pilot here.
All right. Well, and then, of course, it could be any number of other people. The tech giants still haven't made their play here, really, to take it on, but it could be an Amazon. They've got all the pieces. It could be an Apple. Who knows? It could, of course, be employer groups. They are the end buyer in many cases, along with Medicaid programs and Medicare Advantage. So maybe Haven, finally, Tulga Wanda gets it going. And who knows? Of course, it could be one of the big players in the healthcare system now. We put the name of one of the biggest.
Right. I think there's some really room for some exciting roll-ups and a new type of integration in the healthscape.
So I guess we're going to leave you with the final question about the new healthscape is that what's your role in it? Where are you going to play? And I think the next 2 days, we're going to hope that you'll have a chance to a bit further your examination of how you're going to find out. And with that, thanks. And that's our opening remarks.
Thank you. Fantastic.